Well, we can get started in just a minute. Looks like everyone's logging on. So I'll introduce you in just a minute. You're in Louisiana, is that right?
I'm in Louisiana, yep. In New Orleans.
We've only been to New Orleans once and I really enjoyed it.
I've never been to Washington.
Well, you should check it out sometime when people can travel again.
It's always been on my list, so yeah, I'm excited to go one day.
All right, well, I think we can go ahead and get started. A few more people will log on. Welcome everyone to Geriatric Medicine Grand Rounds. We have a fantastic speaker coming to us all the way from New Orleans, Louisiana. And I'll tell you a little bit about Dr. Stevens. He was born and raised in New Orleans, Louisiana. And while he was there, he watched Hurricane Katrina expose the inequities and inefficiencies in our healthcare system. And this tragedy led him to his passion to change healthcare to provide equitable, efficient, and accessible care for all. So after completing his MD and his MBA at the University of Chicago and a family medicine residency at Georgetown University, where he was also a chief resident, he went back to Chicago to join Oak Street Health, which he'll tell us about. He served as the medical director in the south side of Chicago at one of the company's largest clinics, and was the interim program director for the Fellowship for Value-Based Care Leadership. During the pandemic, as all of our roles have changed slightly during the pandemic, so with him, he helped lead the implementation of a program to care for patients diagnosed or suspected to have COVID-19 and was heavily involved in the COVID-19 vaccination efforts, of which Oak Street Health has vaccinated over 31,000 people in Chicago alone. He now serves as a senior medical director in one of Oak Street Health's newest markets, which is Louisiana, which is why he's joining us from New Orleans. Thank you so much for joining us, and I'm really excited to hear what you have to say.
Awesome. Thank you so much, Kate, for the kind introduction. I'm going to share my screen. Perfect. So today what we'll be talking about is just about COVID-19 and how we think about COVID-19, particularly in a value-based care system. And in order to do that, we'll spend some time talking about value-based care, talking about Oak Street Health, and then of course, how we responded to COVID-19. And I have nothing to disclose other than that I work for Oak Street Health. And then again, for the agenda, so we'll talk about value-based care, then a little bit about Oak Street, and then talk about how we responded to COVID-19. But I think it would be helpful for me if we started off with a poll. So I'm going to ask everyone if you can join with your phone or on your browser to go to slido.com, and if you just put in that hashtag. And it's just a couple of short questions. This will help me kind of frame the talk a little bit. And so the first question is, what do you think of value-based care? And we'll kind of wait for the responses to come in. And then again, if for those who are still looking to joining, the information's on the side. Okay, give a couple more seconds. So good, so everyone here is, and I think I've seen these answers change a little bit over the course of the pandemic. And we'll get into that, but it looks like most people are excited and some people are looking to learn more. Okay, very good. And then I'm gonna switch to the second question. And this is again helpful for how much time we'll spend talking about Oak Street Health, but how many people here have heard of Oak Street Health prior to today? Okay, wonderful, wonderful. So we'll definitely I'll spend maybe a little bit more time just giving you all some background, and I'll certainly pause for questions too to talk about our model, because I think you'll see that, COVID-19 in a lot of ways, it exacerbates kind of the existing both positives and negatives about our healthcare system. So, okay, that's really helpful. And then the last thing that's just really helpful for me as well too, is just where everyone is in their career. Okay, wonderful. And I know Kamara, who's also with me, she'll be kind of monitoring the chat, as well, but okay. And I'm gonna guess the fellows are in geriatrics. The most part is that, or you can just put it in the chat room, but.
Yes, and there's probably some palliative medicine fellows as well.
Okay, wonderful. All right, thank you everyone. So that's really helpful, both I think for all of you to learn, but also for us as well too, as we kind of talk about value-based care today. Okay, give me 1 second. I'm just gonna switch to present mode now. All right. So first to talk then a little bit about Oak Street, and I'll pause here for questions after this slide. But so we were initially founded in 2012 in Chicago. And what we are, we're a network of primary care centers for adults on Medicare, including dual eligibles. So since 2012, we're now in 80 locations across 11 states. You'll see that actually Louisiana is even on here, so it's even more than 11 states now. And we have an innovative care model that we're going to talk a lot about that really focuses on integrative team-based care. And again, we are a value-based care system, which means that we are a fully capitated at-risk model. So this means that if our patients go to the hospital, we're paying for it. If our patients see a specialist, we're paying for that. Then of course, on the flip side, if we're able to keep our patients out of the hospital, then we're able to keep those savings as well too. So we have over 85,000 patients. And again, we haven't quite gotten to the West Coast yet, so I'm sure that's probably why a lot of you haven't heard about us yet. But really, our mission is to rebuild healthcare as it should be, and again, which fits very well, right, when we're talking about COVID-19 and our response to the pandemic. And this is really, really, really important to us, and frankly, you'll see this here no matter who you talk to, whether it's our CEO, you talk to the providers, you talk to the MA, and it's really exciting even here at a new clinic when we have new staff. This is how everyone really feels and why everyone joins this organization, is because when we're talking about rebuilding healthcare, we want to make sure it's personal. Again, so we're in the community, we're making sure that we're really talking and meeting with patients kind of on the ground level and making you feel comfortable coming to us and focusing on preventative care. We want to make sure it's equitable. So meaning that a lot of times our community centers are in high risk areas, which we'll talk about as well. And we also provide care that's accountable, meaning that we want to take that responsibility. So we want to, have quote unquote skin in the game. So we want to share the successes, but also we're willing to kind of, pay the cost if our patients do get admitted to the hospital. I guess I'll pause there. We're going to talk a lot more about Oak Street, but I'll pause there if anyone has any quick overarching questions about that.
Dr. Ong put a question in the chat asking what decisions factored into choosing the states that Oak Street is in.
Oh, okay. That's a perfect question. Dr. Ong, I'm gonna write that question down, and so we'll address that when we talk a little bit about value-based care. I think that's going to provide a lot of context. So let me write that down. Okay. Any other questions? Okay, perfect.
It looks like, oh, you got it.
Oh. Okay. So let's talk a little bit about value-based care. I think value-based care is a very nebulous term. In general, when you think about value-based care, you think about value equaling an outcome over a price, divided by a price, right? And that can mean a lot of different things to a lot of different people. There are a lot of different things when you can think about outcomes. I'll pause for a second while you kind of think of some in your head, right, about different outcomes, but they're the ones that we think about when you think about, there's financial outcomes, of course, but there are also things like patient-oriented outcomes. There are also, clinical outcomes, right? So how well you're controlling diabetes, how well you're controlling hospitalization rates or readmission rates. And I think this is something we're still all trying to figure out because when someone throws out the word value-based care, well, value to whom, right? Is it value to the provider? Is it value to the patient? Is it value to the healthcare system? Is it value to the insurance company? Right. And so depending on who you talk to, then, they may think about defining value very differently. And so when you're thinking about a primary care-based company, or when you're thinking about a company like Oak Street, you really have to be very, very careful and be very articulate, right? Because if we just have a value-based care system that's just based on the definition of an insurance company or of the healthcare system, it's not going to meet the needs of every patient that we have. Right. And then also when we talk about price, how do you make sure that we're not providing cheap care, but we're providing high value care, right? So how do we make sure, like, we don't necessarily want to do something just because it's the lowest cost, right? We want to make sure that we are really meeting the triple aim of decreasing costs, but while also increasing the quality of care that we're giving. So, to me, one of the things that speaks to figuring out that we really are still learning frankly, as a nation, or really as a world, about what value is that when you look at like how CMS defines value-based care, it's really not that specific, right? When you looking at all the different programs that CMS has, it looks like we're still trying to figure out how exactly that model works. And then, I think one of the big things about value-based care, when you think about it, and when you think about our current healthcare system, I really encourage you to think about it in terms of incentives. I think a lot of times within healthcare, it can be very, very easy to assume that the person not in the room doesn't have the best interest of the patient or the healthcare system, right? I know as a provider, I can tell you sometimes I get upset or frustrated with insurance companies, right? Like, they don't care, they don't understand. Why are they making me do this prior authorization? All those different things. And sometimes the administrators get mad at the physicians, like they don't understand, they don't get what's going on. But how do we set up a system that really incentivizes everyone to do what's in best interest for the patient? And so this slide here, as you're kind of reading through it, is really just kind of setting the groundwork and the framework for us as we go through the rest of the day, just thinking about what are the different types of payment methods that you could do. And I'll ask a question to the group. So which one of these numbers is the predominant one that we see in healthcare today? And you can either answer a question in your head, or you can feel free to you can take yourself off of mute, or put it in the chat box. But I'll give everyone a second to kind of process this chart. And then the first question would be, which one of these is the predominant one that we're using today? Let me see if I can pull up. Yeah, perfect. Everyone's saying fee for service. Exactly. So from the little clip that you got about us at Oak Street, which one do you think where we fall under? Okay, right. I see some 3, some 2. Yes. So we will fall under 2 under capitation, and then we'll get there. And then the other one I like to call it from the side, because this really for those interested, I encourage you to kind of take a look at this. But this is really another lecture within itself. But to understand incentives, I like to point out number 5. So per day, per diem, per visit. That's one per diem and per visit. So number 4, by the way, is what's most predominant in inpatient services in hospitalist care. But so from number 5 for per diem or per visit, this is what nursing facilities often use. And the reason I think this is a great way to talk about incentives. So you want to put on the hat of 2 different things. One, you want to put on your hat of the insurer, and one on the hat of kind of the nursing facility. So what essentially this means is that if you have a patient, let's say they had a stroke, they're in a nursing facility, that insurance company is going to pay that nursing facility, let's just say $100 per day that the patient is there. It doesn't matter how much a nursing facility spends. So why might an insurance company want to agree to do that? Right. One reason is that it's really easy to figure out. Like, I don't have to calculate, how many times the bed was turned, what your staff ratio is, I don't know how many medications the patient was given, what level of services a person needs. Like, I don't have to figure any of that. I just say, on average, a patient who had a stroke should be in a hospital for, or should be in a nursing facility for that type of stroke for 7 days, right? So I would just pay you the same thing for 7 days. I know what the average cost is. If it starts to get to 10 days, I can start to ask questions why, right? So it makes it very easy to do that. And then for the nursing facility, it's one of the incentives, right? It's really, really nice because then you don't have to worry about, logging every single thing that you do with the port of like, I need to make sure I get paid for every service that I do. You kind of know what your budget's going to be. But on the flip side, if you're a nursing facility, in the good side, you're incentivized, not necessarily to keep a person with a stroke in there too long, but let's say you have a patient, right, and everything is good with them, but they're only on day 5, but you know that the insurance company's not going to ask anything until day 7. Again, good intentions, right? What do you may lean towards doing? You may lean towards saying, like, you may start saying, oh, well, there's no reason, like, you may start finding ways, not in a bad way, but just because that's what's allowed to do. You may find ways for that patient to stay there until day 7, even though they could have gone home on day 5, because you're not necessarily incentive to think about how can I get this patient home earlier, right? So I think that's a really, to me, like a pretty good example to think about, just when you start thinking about the effects and influences of incentives. And again, when we start talking about COVID and the COVID response, I think that's something really, really, really important to think about. Like, what is our healthcare system? What is it incentivizing, providers, hospitals, insurance companies to do? Okay. So to talk a little bit about fee-for-service. So fee-for-service is really simple to understand and to administer. I do something, I get paid for it. I do something, I get paid for it. But this can be very, very difficult for patients when we talk about incentives. And this is what we're seeing right now with our healthcare system. If you do something and you get paid for it and you need more money, what are you going to do? You're going to do more things. You're going to have more visits. As we all know, the quality of care that we can provide to a patient is very different if we have 20 minutes, 25 minutes versus 5 minutes. And so we're not going to be able to focus on that preventative care. And we're going to provide lower quality care. Again, not because we setting out to do that, but because that's the system. No profit, no mission, no profit, no mission. Right? And so if we're not doing those mammograms, doing those colonoscopies, doing those preventative measures, having those more detailed conversations with our patients about how to take their medications, then that's going to lead to more downstream expensive interventions. So then put on your insurer hat. If you're finding that the patients are costing more, what are you going to do? You're going to say, well, I'm going to pay you less. And then as a provider, if you're saying I'm getting paid less, what can you do from there? More patients, more visits, right? That's the pressure, right? You hear it sometimes like, oh, we used to see 15 patients a day, but now we got to see 20. And now they're pushing you to see 25. And it's not because they don't understand that you can't do it, but they got to keep the administrators, right? The non-clinical side, they have to keep the lights on so we can keep serving patients. And the way they do that is by saying, we got to see more, we got to see more. And it gets in this, the cycle, and that's where we're seeing going now. Now, when you think about value-based care, as we're talking about before, value-based care is very complicated. It's very complex. How do you just decide value? How do you align incentives? What are the right incentives? Are you incentivizing the patient? When do you incentivize the patient? All right, so it can be very, very, very complex to administer. But when it's done right, it can really, really, really lead to high quality care, and it can lead to aligned incentives across the value chain. So this is our motto, and I'll tell this to patients, I'll tell this to staff, I will tell this to the insurers, I'll tell this to the administrators, right? Our goal is to keep our patients happy, healthy, and out of the hospital. And I like that because it's simple, but when you really start to break down this phrase, you can see how this aligns incentives. When we talk about happy, a happy patient means it's a patient that's engaged, right? So if we have a patient at our clinic and we want to make sure we're keeping them lower cost, we need to keep them engaged. We don't want to hear about when they get to the hospital that they missed all their past appointments. We need people who are excited to come in. If you're the patient, of course you want to be happy when you come to the doctor or you come to see your provider. Similarly for healthy, everyone wants to be healthy. We want them to be healthy. Our insurer wants them to be healthy because that starts to get at costs. And then the last part as well is out of the hospital. 99.9% of our patients, don't want to be in the hospital unless they have to be. As providers, that's why we get into this, right? We want to provide high quality care. We want to keep our patients, especially in outpatient medicine, right, out of the hospital. And then when you start to look at the administrators and the insurers, what do you think the number one cost of care is? Being hospitalized. So I really love that phrase because, again, you can say that phrase essentially to anybody and they're going to look at it differently, but that shows how the incentives are aligned. So when we talk about the cycle in terms of looking at healthcare, when we provide this value-based care, when we're keeping our patients happy, healthy, and out of the hospital, we're able to take that money that we're saving, we're able to invest it in quality. So it doesn't matter how many patients I see. If I have a patient who's a high risk going to the hospital, I can see that patient, essentially 15, 16, 17, 20, 25 times a year. And that's going to be cheaper than them going to the hospital one time. Just out of curiosity, people can throw out some numbers, but how much do you think one hospitalization costs on average?
$30,000.
$30,000. Okay, good. Any other guesses?
Without insurance, $200,000.
Okay. All right, so the average cost we'll say is going to be somewhere, not quite $200,000, but somewhere around, we'll call it around 15,000, so around 12,000 to 20,000. And then of course you can imagine for COVID, which we'll talk about in a little bit, that cost is going to be a little bit higher. How much do you think on average it costs for a patient to come see us in the clinic? It's going to be about $100. Right, so a really big difference, right? So you can start to see, wow, when we're responsible for that, how much we're willing to do in the clinic to keep our patients out of the hospital. But of course, understanding, right, if a patient needs to go to the hospital, then there's no point in delaying or deferring that. But really, it switches our incentives to think about what can we do to keep them out, as opposed to necessarily defaulting to sending them to the hospital. And so in this slide, this is just kind of a direct comparison. And one of the things I want to call out here is quality metrics. And to me, quality metrics, I know sometimes quality metrics can get frustrating for providers. And I think this is where you really need to think carefully and think thoughtfully about what quality metrics you want to use that are kind of patient-centered, evidence-based, and have appropriate amount of exclusions and exceptions and so forth, right? We don't want to incentivize, let's say, providers to be ordering mammograms for people in hospice, as an example I like to point out too. But at the same time, what the quality measures allowed us to do, it changes the incentives, right? If we're in a fee-for-service and we're not thinking about quality or quality measures, then it's almost like if the patient in front of us, you want to get a mammogram, as a provider, I want to talk to them about it, but I may not just have the time, or I may not, have the extra incentive. But when you're thinking about us as a value-based care company, where we're incentivized, let's say for mammograms, right? We're able to do services like we're going to pick up our patients and bring them to get mammograms. We're like, part of our model is to actually call and get them scheduled for the mammograms. Like, it puts the onus on us to help make sure that we are walking through barriers with our patients to help them get the care that they deserve. And then the next slide I want to point out is another thing that our system, and a lot of you pointed out to this, is moving towards a value-based care system. And you can sign no matter what administration you look at. So our current administration, the previous administration, the one before that, you're going to find that we are moving more towards a value-based care system. So it is important, frankly, for me and as providers, that we're not left behind. That we need to be in the decision room for these kind of decisions, because it's so complex, so complicated. We want to make sure, right, that at the end of the day, we're not incentivized, or one of the, that people on hospice are excluded from measures looking at mammograms, right? We need to be in the room helping making these decisions to protect our patients. And briefly, I want to talk a little bit when you think about value-based care. And then Dr. Ong, I'll answer your question here as well too about how we choose what states to go to. So you really need to make sure that your incentives are aligned. And part of that is we need to know who counts and who doesn't. And I'm gonna lump 1 and 2 together because you need to know who counts before it happens. The example I like to give here is if you're an attending, right, on inpatient, do you want to find out the last day that you're on service that you had a patient that was admitted the entire time you were there and you're responsible for the outcome? Absolutely not, right? You want to know day 1 who are responsible for, who are your patients. When someone's admitted, you want to know all those different things. And that's obviously very, very important if we're going to be responsible for their care. We need to know so we can help get them in. Also, another really, really crucial part of this is the risk adjustment. If I'm just told that I'm going to pay for the health of my patients, if I'm just going to get, say, the same amount per every patient per month, then I'm not going to be incentivized to go and find patients who, have more medical conditions, right? Who are going to be in the hospital, 12, 13, 14 times a year. So we have to risk adjust for the complexity and the disease burden of the patient, right? So we don't want to be cherry picking. And then the last part is the quality metrics. When you're thinking about a population health level, again, this is one of the ways we can show that we're not providing cheap care, we're providing value care, high quality care, the quality metrics. And so when we're looking for states to partner with, we're looking for, places where there's a need. We're looking for places where the insurers understand, how our value-based care system works. And we're looking for places where we feel like we can make an impact on the community that's there. So that's really how we're looking at states. So we want to make sure when we go somewhere, right, that there's a good need and we have partners that can understand our model and help us figure out how to best take care of that population. So, but that's a really good question about how we pick states. All right, so now I'm going to talk a little bit about Oak Street Health. So as I was saying before, our mission is to rebuild healthcare as it should be, and our mission is to focus mostly on underserved communities. And I just want to give a quick background over our demographics. So our median age is 69. Again, we are adults on Medicare, but at the same time, not everyone that's on Medicare is over the age of 65. You have patients on, physical disability, mental disability. I have a patient who's 22 with Down syndrome. A patient is 30 who's, a gunshot wound victim. Patients who are in their 40s with schizophrenia, and so on and so forth. Our average patient has 8 prescriptions. About 30% of our patients are dual eligible, so dual Medicare and Medicaid. The average income $21,000, and so on and so forth. So you can see, so that we really are applying our value-based care model to a complex and sick population. And in order to make sure that we're providing equitable care, we actually provide transportation to and from our appointments. We have a 24/7 call line, so whenever someone calls, they're going to call and talk to a live person. We have telehealth visits and phone visits as well too, and we'll talk about that in our pandemic response. We have, again, same day, next day appointments. Open access is very, very, very important for our model. And as well too, we know that our healthcare system is very, very complicated. So we want to make sure that as people are navigating our difficult healthcare system, that we have people that can really help them understand, their insurance and our insurance and our healthcare system. Now, for us, community engagement is really, really, really important for us. We are in the community, and I'll show that in the next slide. We want to make sure our patients are getting a concierge level experience. We like to partner with local organizations, and we'll talk about this as well with our COVID response. And when we talk about our model of care, we have integrated care teams. So that's social workers and increasingly community health workers. Talking about integrative behavioral health. Thank you, University of Washington, for we definitely use the AIMS model here. And we want to make sure that we have scribes for our providers as well too. So we want to make sure that we really, really, really are having integrated care team. I can tell you here, starting a new clinic, I emphasize with everyone that this patient is not my patient. This patient is our patient. And so this graph here is just really showing that we are in the community. So this is a map of Chicago. I'll kind of point out my old clinic in Chicago was this one right here. And you can kind of see the map of how we mapped place our centers in places where that care really is needed, where our primary care deserts. A great question. I see a question about psychiatric care providers. So yeah, so we utilize telehealth. So we do have psychiatric care services. Telehealth, as we know, is a really evidence-based way to be able to treat our patients. So we use telehealth. So we have telepsychiatrists. Great question. So this is a map that really walks us through how our model works. It starts with an intake and an assessment. So this means, we're meeting with the patient, we call it a welcome visit. We're going through understanding, when I'm doing a welcome visit, I'm just really trying to understand a couple of things. I'm trying to understand their health literacy, and then, the acuity of their sickness. And then frankly, what they're looking for, what are their goals of care? What are they looking for? What kind of social and family support do they have? So we kind of start doing screening and diagnostics then. We're able to pull a lot of access on the back end as well too. I would say we're high tech in the background, but when it comes to our patients, very, very, very high touch. We're gonna combine all the information with, again, a lot of data science. So predicting who's gonna be high risk for COVID symptoms, who's gonna be at high risk for hospitalizations and so on and so forth. And of course, always laying and always, these are always suggestions. And the final call is to that person, that clinician that's in the room. We see our patients very, very, very often, which we know in geriatrics is extremely important. So we'll see our patients every 3 weeks, 1 month, 2 months, or 3 months. Again, a lot of these visits are just going to be social visits, making sure that we're catching everything, making sure that we know what's on. We want our patients to get used to coming in when they're doing well. We're going to have smaller patient panels. Because we're a value-based care system, we spend a lot of time not thinking about the person that's in front of us, but thinking about our entire panel of patients that, again, that's going to be smaller than the typical panel. So we're going to do things like daily huddling, where we're literally going to be talking about Ms. Jones at 4 o'clock, she's going to need a mammogram. Mr. Smith at 2 o'clock, he's here, he was just hospitalized. We don't have his records yet. Can we pull his records from the hospital? We're going to do weekly planning where we're discussing our highest risk patients. So that includes the social worker, includes the nurse, the scribe, the provider, the MA. We're just going over, highest risk, and maybe from a medical standpoint, it may be this person was just diagnosed with cancer. I just had a case where the husband had metastatic cancer, and then the wife was dealing with dementia, and the husband was a primary caregiver. So this weekly planning was a great time to discuss both of them, talk about what are our plans going to be for their care. And then monthly, we're going to review different things, all of our patients that were hospitalized. What things can we do differently? What things we need to do for them now? And so on and so forth. Then on the back end as well, too, we're really thinking about population health intervention. So I mentioned briefly in our behavioral health model, also home care delivery as well, too. So when our patients are unable to come into the clinic, we do things like medication management, like a diabetes program. A lot of work with social determinant support, and a hard to reach team focused on our unengaged patients. Right, so in a value-based care model, if a patient gets lost, we're incentivized to go out and find them, to plug them back into care. So entire team to do that. Then of course, we have wraparound services as well too. So we have a transitions and care program. So meaning that we have nurses in the pre-COVID world that would literally go out to the hospitals to see our patients in the hospital. Not because we're gonna manage them in the hospital, but just because we wanna know what's going on. We wanna help with discharge planning. And that way, when they come out, we can do those med recs immediately, because we know that a lot of things can happen from the time of discharge till we see them in the office. And I'll pause for questions in about 2 slides, but I just want to show that some of the results for our model to show that it does work. We reduce hospitalizations by almost half. We reduce our readmissions rate again by almost half. Our patients are extremely happy with us. We have a very high net promoter score. We've reduced ED visits, again, almost by half. And we choose very, very high quality care. So I'm going to pause there for questions in general about Oak Street and our model, and we'll spend the remaining time just talking about how we respond to COVID-19. So I see one question about chaplains and spiritual care providers in the value-based care system. So just that's a great question. I would say that the way we think about it is we look at the community need, and we decide two things. We decide either community meet that need ourselves, like do we in this case, will we hire a chaplain, or do we look for community partners, meaning that we're not experts in this, but we want to partner with someone that can, because we really, again, going back to our model of keeping patients happy, healthy, and out of the hospital. If we're doing one of those things, then that's what really matters to us, not necessarily looking at the money on that side. So while we don't have necessarily, at least at this time, have any chaplains or spiritual care providers within the value-based care, I think what we would probably do if a patient were interested in that, we will look to partner with them. So for example, a lot of times we do partner with churches, for example, to help provide services. If that does not answer the question, then please let me know.
Dr. Stevens, yeah, I was wondering if you could expound upon and give a little bit more detail on in terms of what the social determinant supports look like within Oak Street Health, and what type of support. I think that the experience that I personally have is taking care of these complicated patients who definitely qualify for additional ADL support, such as a caregiver, but working through the state takes so much time, and working through the system. And so in that period of time, they could be hospitalized just because they just don't have that additional support at home or within a nursing home, which causes the cost from a population standpoint to increase. And so does Oak Street Health provide any type of that support? And if you can expound on the social determinant support and what that looks like.
Sure. So that's a great question. I will say this. I would say the social determinants of health, honestly, it really starts with knowing first, and that's us kind of figuring that out. So, literally within the first 2 visits, we're doing a social determinants of health screening. So we're using the VES 13. We have a kind of a customized social determinants of health screen that we do as well too, that looks like things like loneliness. So the first part for us is certainly identifying that. Then the second part is, for those we do identify with the risk factors or something going on, our MSW is a complete head to toe assessment of asking all of those questions. And then typically what we'll do is we will partner with home health companies as well too. So for example, when I'm coming down, to a new market, that's one of the things I'm looking for proactively, is what home health companies can I work with that have good reputations, that are going to do right by our patients, are going to be able to get in, they're going to give us going to give us feedback. That's going to be a bi-directional relationship, because to your point, that's so crucial to our model. And then as well too, then when we start to think of a little bit past the continuum of care, meaning, when it's not just ADLs, but it's wound care, or they're bedbound and they can't get out of the care, then that's when we start thinking about we have a program called Oak Street Health at Home. So that's when we think about physically having, a nurse practitioner, another provider, physically going out to the house at whatever frequency needs to be done to get there. And then you can imagine, not necessarily in our case, but you can imagine people in the value-based care, right, thinking about how do we go one step further than that, in terms of thinking about if someone, doesn't need to go to the hospital yet, but if things keep going on their path, they may need to go in, 12 hours, 24 hours, et cetera, and they can't get out the house. So how do we use data and use people to triage those patients, to identify those patients, and those high-risk patients to be able to get out there to do what we can in the house to keep them safe. So, but that's a great question.
And then I take it that it sounds like you partner with the home health, and the home health agency bills you rather than CMS for separate services.
So it's interesting in some ways how the billing works, and frankly, it depends a little bit on the arrangement. But I would say it's typically, right, since we are all of our patients are on Medicare or Medicare Advantage. So typically, what happens is we will end up seeing that bill, even if we're not necessarily paying it, right right at the beginning. You can imagine, doing that contract tons of different ways, and that's certainly far from my expertise. But you can imagine, right, literally us getting paid up front. You can imagine us getting paid like a part of it at the beginning, and then like a reconciliation, at the end, just depending on the cost, and so on and so forth. But so typically we may not necessarily be the one, when we refer someone, like physically writing to the check to them that day, but we do know at the end of the day, and they know as well too, that we're going to be the ones paying for it. So when it comes to things, I think also what you're alluding to as well is like the authorization piece as well too, right? You can imagine as we start to learn more and more and more, you can imagine a value-based current company thinking about, we want to do the self-prior authorizations and not necessarily depending upon other people. But good question. I see another question here as well too. Reading through it, collaboration with public health, home health, health policy. I think we addressed some of the emergency response community partners. Yeah, then again, I think we're looking at all of that. And we're going to talk about at least some of that when it talks about COVID-19 in a second. But really, I think taking a bigger picture approach to this, again, our model is what things are stopping our patients from being happy, healthy out of the hospital, and whatever that problem is in a particular community, we're going to find a way to try and solve it. Right, is what it comes down to. So if it's home health, and that's a big issue, we're going to find that health hazard, i.e. pandemic, right? We're going to find a way to, find out about that, and so on and so forth.
It looks like there are tons of questions coming in. I don't know if you want to take them now or save them for the end. I'll leave it up to you, but I think they'll keep coming.
Okay. but thank you, Kate. I'll keep on going because I do think this next section may answer a lot of questions that I see popping up, and then we can spend the rest of the time talking about that. So, as we all know, COVID-19 has highlighted and continue to highlight healthcare disparities. Our population we're kind of reading through it, right? If you start to look at all the risk factors for COVID-19, our patients are going to have a lot of that, whether it's kind of just their physical age, whether it's comorbidities or the social determinants of health. But because of our model, just taking a step back, because we're getting paid per patient per month, our revenue didn't change at all over the course of the pandemic. We didn't have to see more people in center. In fact, in some ways, we're incentivized to see less people in center. And our main goal was to provide high quality of care. And we have very high support staff to provider ratios. So that allowed us to reach out to patients more actively. I want to spend a little bit of time. This is, a similar map from before, but just showing how we thought about COVID-19. And as everyone is reading this, I'll highlight two things that have kind of changed from the beginning of the pandemic towards the end. Now with vaccines, of course, you can imagine vaccines is a big part. We want to make sure all of our patients, understand both the pros, the pros and consequences, pros of getting the vaccine, the consequences of not getting the vaccine, and helping them kind of divide and make that decision for themselves. We also as well too want to make sure we're keeping our staff and patients safe. So setting risk stages, just kind of depending on what's going on within the pandemic and, in that area that the clinic is in. So to make sure we're able to see our patients as needed, but also providing appropriate safety measures. We're also dividing each of our patients in a couple of categories. So we had a COVID care program where we're dividing patients into no symptoms or low risk, or if they're high risk, or if they're presumptive positive or known positive, where early in the pandemic, I was literally calling some of my patients who had COVID-19 every single day. But then, which, a lot of providers are doing, but the nice thing for us, it was actually built into my schedule. So it wasn't, because it didn't matter if I was billing for it or anything like that, right? It was just me calling because that really, really, really was a part of our model. And this is actually when we started screening for loneliness and screening for depression. And to me, that's one of the, one of the, I think, under talked about things is just not necessarily the direct impact of COVID, but how COVID has impacted, everyone's mental health. I had seniors saying that, like, essentially, if I can't see my grandkids, then what am I doing, right? That's the whole reason I'm alive. That's the whole reason I'm dealing with all these different things. So how do we spend more time with them? And another thing we did as well too, 3 times a week, again, during 9 to 5, this is actually planned in our schedule because It's not about how many patients see per day, but we're huddling to review our highest risk patients. Also be able to do remote monitoring. So, sending patients out who needed it, like things like Gatorade, pulse oxes, those kind of things, because we know that right at the time our hospital systems are overwhelmed early on in the pandemic. And then on the outside, and I think this is where we start to get with actual care partners. We are in the community, we want to be in the community. And frankly, we are also incentivized to make sure our community is healthy. So for us, this includes community vaccination. As the physicians know in the room, we rarely give shots, but we had all our providers giving COVID vaccines. I personally vaccinated now, probably somewhere over 300 patients. And what we're doing is, right, first we're vaccinating community health workers, right? So that's dentist offices, home health workers, those kind of things, right? Because it's the right thing to do. And I want to incentivize that everyone in healthcare, for the most part, wants to do the right thing. But today I just want to focus on, we're actually incentivized to do that, right? Because our communities are healthy. When we have the home health worker that's going to our patient's house, we want them to be vaccinated. And then as well too, we want to vaccinate the community. So we are vaccinating our patients, of course, but we also want to vaccinate those within the community. Again, because it's the right thing to do and we need to do that thing. But then also when you put on the business side, if you're talking, to the executives, or we want to make sure our communities are healthy, because that's going to affect our patients. So again, focusing on the incentive piece. And let's spend a couple more slides talking about the vaccination efforts. So just reiterating our motto: happy, healthy, and out of the hospital. And again, vaccinations of our communities saves lives, hospitalizations, medical costs, health system, patients, and to us. And because of our model, we're able to engage and activate older adults. I can say, like, for our clinic, because we knew the importance of the vaccination as an outpatient clinic, we were able to buy one of those Pfizer freezers that we no longer need, but at the time that we knew we were going to need, before we even knew we were going to get vaccines. Because for us, it was worth that investment. And then for us and for healthcare, for our population, the trust is appropriately, it has to be earned. It's not just given to healthcare. And so for us, by vaccinating the public and working with our seniors early and often, allowing us to really keep building up that trust, that's so important. And again, our goal is we want care that's equitable, right? So this 100% hits with us. We're in the community. A lot of times the communities that we're in didn't have equal access to the vaccines, certainly earlier on this year. And so we needed to be involved with that. So again, we started off by vaccinating with employees and community health workers in evenings and the weekends. And then now what we're doing as kind of the vaccine access opens up, we have in-center, we have mini clinics. So working with the communities, working with partners to help, this is another place, right, where we can work with local partners. So do you have seniors, do you have others that need to be vaccinated within the community? Great, bring them here. We're happy to vaccinate them. We can work together to do that. Within Chicago, we partnered again with the city of Chicago. We worked with the Chicago to identify 15 high-need communities, and we partnered with them to help vaccinate over 10,000 community members in only 8 weekends. And you can see from that picture, those people were in green, bright green. That's one of our colors. Those are people that work with Oak Street. So again, very, very, very important for us, obviously, to vaccinate our patients, but also to vaccinate our communities. And just kind of shows just what we've been able to do. So 60,000 plus across 8 different states, 21,000 plus community members, and then really working with our local officials and local partners. So that's something, for example, here in Louisiana, we've been doing down here as well, as soon as we started. All right, before we get to questions, as interim fellowship director, for those of us, I'm sure a lot of us in medical education, if I didn't at least briefly mention the fellowship before we get to questions, I wouldn't be doing my job. So here at Oak Street, we have a unique partnership with the Kellogg School of Management called the Fellowship for Value-Based Care Leadership. And it's a 24-month program where you get firsthand experience and knowledge of working with executive leaders and rotating through and understanding population health, clinical operations, comprehensive care design, but also obtaining an MBA from Kellogg, sponsored by Oak Street Health. And then the goal of this is really for young or for new clinicians that are interested in healthcare leadership, interested in learning more about value-based care. So if anyone's interested, please feel free to reach out. But I'll spend these last 9 minutes going through questions. Okay, what's the best way? Should I go back up and read them? Is it better if you or Kamaya kind of read them out to me? What do you think?
I can read them out to you. Let me.
Okay.
I have to scroll up a bunch, and there's so many questions. There was a question about what provider satisfaction looks like in this model.
Sure. So provider satisfaction, is I would say it's very high. I would say what I say to people is when I'm talking about, interviewing people is that we have more time with patients, we have less visits, you have a smaller panel, but it's not because the work is easy, it's because those things are needed. So we're spending that time thinking about our patients, but I would say the one thing you kind of consistently see, again, is that people are really excited about the mission and really passionate about the patients and really feel like they're making a difference. And I would say that is the providers, but I would also say that's the MA that feels that way. That's the front desk staff that feels that way as well too. I'll give a personal example of, again, one of the big things we're doing was mammograms, right? Even once it was safer towards the end of last year. And so what we were doing is we were literally calling our patients, we were picking our patients up, and we were bringing them to get the mammograms from the hospital or from there, right? So one patient who got their mammogram that was so excited that we were able to pick them up and bring them there, she came to the clinic just to say thank you to everyone. Right, and so when you get things like that, we all work extremely hard, but we all have a lot of fun, and they were all really, really, really satisfied with the outcomes and the care we're able to provide to our patients.
That's awesome. Yeah, that's really wonderful. I see a question from Amy. She's wondering if you reach rural areas or if all of the clinics are in urban areas.
Sure. So we do have some clinics that are in more rural areas. Again, we're kind of looking for, places, in general, where there is a high need. And I will say, I think the one thing for us that we have to think about is, for a value-based care to work, you have to make sure that we're eventually able to reach a certain number of, there's a certain number of patients that will benefit within the area for our services. So I think that's kind of one of the things we're looking for and concerning as well too. Because as you can imagine, if you only have one patient, that one patient has the hospitalization that costs $200,000, that can make it a lot more difficult than if you have those, 100, 200, 300, 400 patients or so on and so forth. So we do have some that are more rural settings. But again, it kind of really depends on that particular area, but that's a great question. Great.
The next question is whether Oak Street has considered implementing hospital at home.
Wonderful question. So I would say that, as you can imagine, that's certainly something we're thinking about. And the way we kind of think about things in our system, again, is looking at identifying a problem and then deciding, is it best for us to do it? Is it best for us to have a partner to do something? But I would say that that's certainly something that would make a lot of sense for us to do. Again, it's just making sure, that we're providing the right resources to the patient, doing it in a safe way for that patient, and having, enough patients where that makes sense. But that's a great question. And we're always thinking about all the way across the value chain. What can we do safely? What can we do effectively? How can we provide that higher value of care?
This is an overarching question from Dr. Grunwald. He asked how you monitor and support. He says, how do you monitor and support the health and capacity of your team and organization to reinforce Oak Street's ability to meet the needs of your patients in all of the key dimensions? So.
That's a great question. So for us, taking care of our staff is very important. I like to say, if lifeguards, the first rule of lifeguarding is you can't save yourself and you can't save that person. So making sure that our staff, feels extremely well supported is very, very important for us. And we do that in a lot of ways. I think the example I'll use right now is around diversity and equity and inclusion, which is becoming more and more of light, and certainly was of light, during the pandemic. So we made, personal space and, had actually had trainings and safe spaces for staff to kind of get through and talk and understand the current issues that were going on, why they were going on, and offering people support. COVID obviously affected our patients, but it also affected staff and affected communities and family as well. So that's another area as well to where we were looking to support and to find people whenever we can. Another way as well too is, how do we, a lot of staff, right? When you talk about childcare as well too in the pandemic, as we're trying to figure out this work from home, coming to work. So, working to make sure that we're providing the appropriate, the appropriate resources for our staff there as well. So that's certainly always top of mind, and something that we take very, very, very seriously when we're looking at the different situations. But that's a great question.
Thank you. The next question is Dr. Kim is wondering how you've been able to support older patients who aren't able to easily access or utilize telehealth.
Yes. So that was right. That was a lot of fun figuring it out. So for background, when we within the first week of the pandemic, we switched from no telehealth visits to about 90% phone visits. And then as we start to figure out, right, we need to switch to video visit, right? And then you're right, how do you get someone who, how do you work with those who may have a little bit more struggles with technology to get video visits? So video visits were very, very important to us. Again, going back to the happy, healthy, and then on this one, it's kind of out of the hospital. So we were incentivized to literally mark those who couldn't. We did everything from deliver, we repurposed our vans to deliver tablets to patients. And the van driver actually go in the patient's home and turn on the video and set it up for them, and then take the tablet out there. So we did things like that. To those who fell somewhere in between, they would spend about 15. I think the longest at our clinic was like 45 minutes, like literally on the phone with the patient, walking them through how to set up the video phone with them. For those, because we didn't want to use up the provider's times. For those that struggled, we would flag that, and then they would get a call, later that day, to kind of go through and figure out this is how you do the video visit. And then frankly as well too, what we found is that nothing, especially for our population, replaces the in-person visit. So as things got safer, as we figured out how to operate in this new environment, we started to more so shift our efforts to focus on how do we safely get our patients into the center. So then that starts to go with picking our patients up. But for those that didn't, we had a whole team dedicated to figuring that for helping those who had some struggles. But great question.
There were questions about which specific screening tools you use, if you use a specific screening tool to screen for loneliness and social determinants of health. And specifically, Dr. Starks asked if you use the VSH13.
Oh, sure. Yeah. It's the VES 13. So the Vulnerable Elder Survey, and 13 is for 13 questions. Is one of the certain screenings that we use.
Great.
Mm-hmm.
And is there a specific one for loneliness that you use?
That is a great question. I think I would have to follow up to figure out the exact name of that one.
Fantastic.
That's okay.
We have had all these questions, and that was the first one that you have to get back to us on. That's amazing. Dr. Hirano is wondering whether you've studied provider burnout or work spread into home time in the model. She imagines there would be less moral distress and maybe less burnout and better sustainability.
So yes, that is something we definitely watch very, very, very closely to make sure that our providers aren't getting burned out, and then also when they're getting there, how do we help to provide resources for people that were, and so. That's something, obviously we are a high tech organization. So you can imagine, right? We didn't get to talk about, we have a kind of a homegrown EHR. So you can imagine looking at and identifying things like who's spending a lot of time spending at home, right? You can kind of start to log those types of things. So that's something we definitely have been looking into. When we do find that our providers are, tend to be pretty happy. I would say for everyone, last year was a very, very stressful year. So it was more about how do we help our providers especially deal with that? How do we give them safe spaces to deal with, to deal with what was going on, because there was a lot going on. But in general, yeah, we do have very, very happy providers.
Great. And then we're at 9 o'clock, but we have 2 questions related to funding. Folks are trying to figure out how this all is funded. But it's one participant, Claire Richards, said she imagines that some of this could be funded by the Robert Wood Johnson Foundation Systems for Change, as it addresses the wrong pocket problem. And then our division head, Dr. McCormick, asks if there's secondary insurance for really expensive situations like ECMO, things like that have unfortunately come up more commonly in the pandemic.
Yeah, sure. So for the first part, that's you're right about places like the Robert Wood Johnson Foundation. For us, we're actually a privately owned company. So that's how our funding model works. So it's not through grants or in general or things like that, but privately owned. And then frankly as well too, we are a publicly traded company as well too. For those as you start to do your research on us. And then the last thing I'll say to that as well too is that we do definitely find that our model works, and that's why we're continuing to expand at the rate that we're expanding. But we do find certainly that our model does work and it does decrease costs. And then I think the second question is around secondary insurance. So again, some of it gets in a little specifics with contracts and things like that, but I would say in general, we do take on 100% risk. And so, we're paying for, we are paying for 100% of the hospital costs. There are certain situations, we talk about carve-outs, is when you're talking about like ECMO or different things. One thing in particular, for example, sometimes these kind of systems may have a carve-out for is things like transplantations, because after someone's had a transplant, then their medical care the transplant process extremely expensive and so on and so forth after that. So sometimes there are some carve-outs that are there, but in general, we're taking 100% risk. And I love that because it puts the onus on us. And how do we find creative ways? How are we incentivized to keep our patients happy, healthy, and out of the hospital? For that, when those patients do have those situations, that it's part of the reason.
Fantastic. We're at 9:03, so I think we'll have to close questions for now. But maybe would you be okay if we sent the last few trickling in questions to you to answer?
Yeah, definitely. And I'll get back about the loneliness as well.
Thank you so much. Thank you so much for teaching us more about value-based care and this model and sharing all the wonderful work you're doing and building us all up, because this is such a great model to really get patients what they need when they need it. And you seem very happy doing it, as does your team. So it's really uplifting at a challenging time for everyone. So thank you for sharing this with us.
No, thank you, Kate, and thank you, everyone. This is a really engaging group, so I really, really, really appreciate that. It's not bad for a Friday.
Thank you so much. Have a great weekend.
Thank you, everyone. Please feel free to reach out for any questions. Everyone, have a great day.
Thank you.